Imagine this. A seemingly healthy 28-year-old,
Uh,
full of life, just back from a bachelor party, laughter, friends, maybe too many celebratory toasts. You know how it goes.
mm-hmm.
But then, just 2 days later, that whole celebratory feeling,
Yeah.
completely gone. He's in the emergency department. He's got dizziness. His heart is just racing. These really unsettling palpitations won't quit.
Right.
Now, his symptoms alone, dizziness, palpitations, they could point you in like a dozen different directions, couldn't they? They're just so common.
Absolutely. They're non-specific in many ways.
But the true story, the real diagnosis, often isn't just shouting at you through those, alarming symptoms. No, it's often whispering in the subtle details of his history, and crucially, etched right there in the squiggly lines of an electrocardiogram.
You've really hit on a fundamental truth there in clinical medicine. The initial presentation can be incredibly deceptive, a medical red herring if you're not looking closely at the full picture.
Yeah.
It's a classic scenario where context, patient demographics, and those seemingly minor historical details become absolutely vital in separating the truly significant from, well, the simply plausible.
And that, my friends, is exactly what we're diving into today on The Deep Dive. We're taking a truly fascinating look at a pivotal clinical case study. We're armed with a patient's detailed history, a critical ECG, and a whole lineup of potential diagnoses.
Mm-hmm.
Our mission today isn't just about finding the right answer. It's about mastering this information. We're going to thoroughly dissect why the correct diagnosis is unequivocally spot on.
Right.
And maybe even more importantly, for getting that true understanding, why each alternative, no matter how tempting or, superficially similar, just doesn't fit.
Exactly. It's about digging deeper.
We'll explore the nuances, the common pitfalls that trip up even seasoned medical students and practitioners, and really aim for those aha moments that transform raw information into genuine, lasting insight.
It's really about cultivating that critical reasoning skill, isn't it? Moving beyond mere pattern recognition to understanding the underlying physiology, the specific diagnostic criteria, and those subtle clues that truly define these conditions. It's clinical reasoning in action,
Yeah.
allowing you to not just identify, but truly comprehend.
Exactly. So let's meet our patient. As I mentioned, he's a 28-year-old man, previously healthy, no known medical issues, who suddenly finds himself in the emergency department.
Okay.
He's been experiencing dizziness and those unsettling palpitations for about 2 days. And here's the key, the real nugget of information that sets the entire stage.
Mm-hmm.
Prior to the onset of these symptoms, he attended a bachelor party where he lost several drinking games. Now that phrase, lost several drinking games, it's not just some colorful detail thrown in for flavor, is it?
Oh, absolutely not. That's not just flavor. It's a critical piece of the diagnostic puzzle.
Right, it's practically screaming acute alcohol consumption at us.
Precisely. It immediately presents a potential etiological factor, a trigger that, once you recognize it, can significantly narrow down your diagnostic possibilities even before you get into the intricate details of the ECG.
Yeah.
It's a cornerstone of the case.
So the core challenge we're grappling with today is this. Given this young man's history of acute alcohol intake, his symptoms of dizziness and palpitations, and the ECG right in front of us, what is the most likely diagnosis from the options provided?
Yeah.
It's a high-stakes question, one that demands a meticulous approach, blending that careful history-taking with precise ECG interpretation.
Definitely.
Okay, let's unpack this and start with the patient's electrocardiogram, because those squiggly lines are often where the truth really lies, right?
Yeah.
They offer
Yeah.
an immediate window into the heart's electrical activity.
Mm.
We've got a visual here,
Yeah.
and to my eye, there's a lot going on. Some of it looks quite chaotic. Where do you even begin to make sense of this? What's the very first thing that jumps out?
That's a great starting point. The very first thing that strikes me and should immediately capture anyone's attention is the rhythm itself. If you glance across the rhythm strip, that long tracing usually at the bottom of the ECG paper,
a long one.
you'll observe that the RR intervals, the distance between successive QRS complexes, are highly variable. There's no consistent pattern.
Right, they're all over the place.
Exactly. This immediately tells us we're dealing with an irregularly irregular rhythm. This isn't just slightly offbeat, it's truly chaotic and unpredictable, which is a very significant clue.
Okay.
It indicates that the signals controlling the heart's beat aren't coming from a single organized source in a regular fashion.
Irregular. I like that description. It perfectly conveys that sense of disorganization. So the rhythm's a mess. What about the P waves? The little bumps that usually come before each QRS complex, signaling the atria contracting. Are we seeing those clearly?
Ah, the P waves. This is another absolutely crucial observation, building on that irregular rhythm. When you really scrutinize the tracing, particularly in leads like TI or V1, where P waves are often most prominent, easiest to spot,
Yeah.
you'll notice a distinct absence of clear, organized P waves before each QRS complex.
Okay.
Instead of those distinct rounded bumps, you might perceive a baseline that looks, well, somewhat chaotic, maybe tremulous or undulating. We often call those fibrillatory waves.
Debilitatory waves, right.
But critically, there's no organized atrial activity, no distinct P wave signaling a coordinated atrial contraction. The atria are just, they're not contracting in an orderly way.
Okay, so no clear organized P waves and an irregular rhythm. That's already narrowing things down quite a bit in the world of tachyarrhythmias.
It really does.
And what about the QRS complexes themselves, the main spikes, the ventricular contraction part? What's their width telling us?
Good question. The QRS complexes appear narrow. To be specific, their duration is typically less than 0.12 seconds, or, less than 3 small squares on the ECG paper.
Right, a standard measure.
And this narrowness is incredibly important because it tells us that the electrical impulse, whatever its origin might be, is traveling through the ventricles using the normal rapid conduction pathways, the bundle of His, bundle branches, Purkinje fibers.
Got it.
A narrow QRS complex generally points very strongly to a supraventricular origin of the rhythm, meaning the electrical activity is starting above the ventricles, right, in the atria or the AV node, and then conducting normally down.
Okay.
This immediately helps us start ruling out many ventricular arrhythmias.
Right, so just to summarize our initial look, we have a rapid rhythm, it's irregularly irregular, no discernible P waves, and narrow QRS complexes. These initial objective observations, they're going to be our bedrock as we look at the choices, right?
Absolutely. They are the concrete facts we'll keep coming back to, the non-negotiables of this case.
Okay. Now, with those foundational ECG observations locked in, let's dive into the most likely diagnosis, which is choice C, paroxysmal atrial fibrillation, or Afib for short. This feels like where all the pieces might just click together.
Indeed. Paroxysmal atrial fibrillation is classified as a supraventricular tachyarrhythmia. And as we just discussed, that supraventricular part means it originates above the ventricles,
Yeah.
which lines up perfectly with our observation of narrow QRS complexes.
Okay.
What's fundamentally happening in Afib is that instead of the atria, the heart's upper chambers contracting in a coordinated, organized way, they're essentially just quivering or fibrillating.
Quivering, yeah.
They're being bombarded by multiple chaotic electrical impulses from various ectopic spots, often around the pulmonary veins. This uncoordinated atrial activation means the atria aren't effectively pumping blood into the ventricles. They're just kind of twitching.
And we're talking specifically paroxysmal Afib here. What does that mean exactly? Like it comes and goes?
Exactly. Paroxysmal means it starts suddenly, and then often just as suddenly it stops on its own. Usually within about 7 days, frequently without any specific medical intervention needed to restore the normal rhythm.
Okay. So why is this the perfect fit for our patient, given everything we know, the history, the symptoms, the ECG?
Well, let's connect it directly to our patient's clinical picture first.
Yeah.
His symptoms, the dizziness, the palpitation, they're classic manifestations of Afib.
Right.
When the atria are fibrillating, the ventricular response becomes rapid and often inefficient because the AV node is just getting hammered with impulses. This rapid, erratic beating can lead to reduced cardiac output, especially in a young, active person who might need more blood flow. This reduction in blood flow, particularly to the brain, can directly cause that feeling of dizziness.
Makes sense.
And of course, the heart beating so rapidly and irregularly is precisely what people perceive as those unsettling palpitations, that feeling of the heart fluttering or pounding. So the symptoms fit perfectly with the physiology.
And this is where that bachelor party story really slots in, isn't it? The losing several drinking games, the acute alcohol consumption.
This, for me, is the golden nugget. It's the unmistakable giveaway that just screams for recognition in this kind of clinical vignette, and it's a prime mastery point.
Right.
Acute alcohol consumption is an incredibly well-known and potent trigger for paroxysmal Afib, so much so that it has its own distinct, widely recognized clinical term, holiday heart syndrome.
Holiday heart syndrome, right, I've heard that.
This syndrome describes exactly what our patient is experiencing, an acute onset of atrial fibrillation, or sometimes other arrhythmias, like atrial flutter, directly triggered by excessive alcohol intake. It's often associated with binge drinking during social events, holidays, or, like in our case, a bachelor party. The alcohol directly affects the heart's electrical system. It can shorten the atrial refractory period, making it more susceptible to these re-entrant circuits that lead to fibrillation. So this perfectly fits our patient's history. It provides a clear, direct etiological link to his symptoms. Overlooking this connection is a really common trap. People focus too narrowly on just the symptoms or the ECG without integrating that powerful context.
So the symptoms fit, the history fits beautifully with holiday heart syndrome. Now, let's go back to the patient's ECG and explicitly point out how those initial things we saw confirm Afib. It's like the ECG is singing the Afib song once you know the tune.
Exactly. Let's hit those three key features again. First, the irregular rhythm, as we discussed, this is the hallmark. That chaotic atrial activity leads to unpredictable conduction through the AV node.
Right, the bouncer analogy.
Yeah, the AV node acts like a gatekeeper, letting some impulses through, blocking others, but with no discernible pattern, hence the erratic ventricular response. Second, the absence of distinct P waves.
Yep.
You just won't find those regular, organized atrial depolarizations because the atria aren't contracting properly, they're fibrillating. You might see that wavy, chaotic baseline, the fibrillatory waves. And finally, the narrow QRS complexes. As we established, this tells us the impulse, despite its chaotic origin in the atria, is still conducting down through the ventricles via the normal fast pathways.
Got it.
This is a critical distinction separating it from ventricular arrhythmias, which would show wide QRS complexes. All three of these irregular, no P waves, narrow QRS, are the classic undeniable diagnostic criteria for Afib.
Okay, so the picture is remarkably clear and consistent across the board: history, symptoms, ECG. What about the prognosis and management for this kind of paroxysmal Afib, especially when it's triggered by something specific like this?
Well, for paroxysmal AFib, especially a first episode that's clearly triggered by an identifiable factor like acute alcohol, like in holiday heart syndrome, the prognosis is generally quite good.
That's good news.
Yeah, the excellent news for our patient is that it often subsides spontaneously, usually within that 7-day window, even without specific medical intervention to, shock the heart back into rhythm or anything. The immediate advice for this patient, and this is profoundly crucial for preventing it from happening again, is complete and permanent abstinence from alcohol in the future.
Right. The source material was very clear on that.
Exactly. It explicitly states, to prevent similar episodes, this patient should abstain from alcohol in the future. This simple yet powerful lifestyle change addresses the root cause for this specific patient and can be incredibly effective. For some people, even moderate alcohol intake can be a trigger, so complete avoidance is often the recommendation.
That's a really powerful and straightforward recommendation. It just shows how lifestyle choices can have such direct cardiac consequences.
Mm-hmm.
Now, thinking about those MCQ traps and real mastery points for a case like this, what are the key things we should just burn into our brains?
Okay, a significant trap and a critical mastery point is getting too focused solely on the presenting symptoms, the dizziness, the palpitations, without meticulously integrating the patient's complete history, especially the social context. Lots of things can cause those symptoms, right? But the holiday heart syndrome link with acute alcohol is a specific diagnostic entity. Knowing that association with paroxysmal AFib is a common giveaway in clinical vignettes that learners often miss if they don't probe the social history.
Right. Don't skip the history.
And never skip the history. Another mastery point is being able to confidently distinguish Afib on an ECG from other irregular rhythms. For example, multifocal atrial tachycardia, or MAT.
Oh, yeah, Matt.
MAT can also be irregular and rapid, but the key differentiator for Afib is the absence of distinct organized P waves and that chaotic fibrillatory baseline. In MAT, you'd actually still see distinct P waves, they just have varying shapes, like at least 3 different morphologies.
Okay, subtle but crucial difference.
Very crucial. It requires careful visual inspection. So this holistic approach, symptoms, history, and specific ECG findings, that's what leads to true mastery.
Excellent. So Afib is our clear frontrunner, strongly backed up by everything we've discussed. But to really master this case, develop that robust clinical reasoning, we need to understand why the other choices, even if they seem plausible at first, are definitively incorrect.
Exactly. It's about building that diagnostic certainty by understanding the alternative.
It's like building a fortress around our correct diagnosis by knowing why the alternatives just can't get in. So let's move on to choice A, hypertrophic obstructive cardiomyopathy, or HCM. This is a serious condition, and yeah, at first glance, some symptoms might overlap. Why isn't it this one?
Right. HCM is definitely a significant condition. It's primarily a hereditary disease, usually passed down in families, characterized by this asymmetric hypertrophy and abnormal thickening of the left ventricle, often specifically the interventricular septum.
Okay.
This thickening can sometimes obstruct blood flow out of the heart during contraction, hence the obstructive part. Now, many people with HCM are actually asymptomatic for a long time, or it's found incidentally. But it can certainly cause serious issues like syncope, fainting spells, lethal arrhythmias, even sudden cardiac death, especially during, say, intense physical exertion.
Scary stuff.
Very. And yes, you're right, palpitations and dizziness can occur, maybe due to the heart struggling to pump efficiently or because of associated arrhythmias. That creates that superficial overlap with our patient's symptoms.
Okay.
Which is exactly why it's a tempting but ultimately incorrect choice in an exam situation.
So, if the symptoms can overlap, what really sets HCM apart from our patient's acute presentation, especially when we look at the ECG? This is where those structural changes or lack thereof should be visible, right?
Absolutely. The ECG findings in HCM are quite specific, and they directly reflect those underlying structural changes, that thickened muscle.
Okay.
A typical HCM ECG would show really characteristic patterns. You'd often see deep, narrow Q waves, especially prominent in the inferior leads 2, 3, AVF, and the lateral leads 1, AVL, V5, V6.
Deep Q waves.
Now, just to be clear, small, narrow Q waves can be totally normal, representing septal depolarization. But the deep, wide pathological Q waves we see in HCM are different. They signal an abnormal electrical activation pattern, often from that thickened muscle or septal hypertrophy, a very concerning sign.
Okay.
Additionally, you would typically see clear signs of left ventricular hypertrophy, LVH, on the ECG.
LV.
Meaning the R waves in certain leads, like V5 or V6, would be abnormally tall, and the S waves in leads like V1 or V2 would be abnormally deep. Reflecting that increased muscle mass in the left ventricle, these patterns are quite distinct, direct electrical signs of that structural remodeling.
And if we compare that picture to our patient's ECG that we just reviewed?
Crucially, our patient's ECG in this case does not demonstrate these characteristic findings. We don't see those deep pathological Q waves. We don't see the prominent voltage criteria for LVH that you'd expect in HCM. If you look at the example HCM ECG provided in our source material, you can clearly see those profound Q waves, the significant voltage for LVH. Our patient's ECG just doesn't show that picture of chronic structural change.
So, despite some shared symptoms, the ECG definitively rules it out. What are the key reasons it's incorrect then, especially considering he was previously healthy?
The primary reason is the complete lack of those specific chronic ECG signs. No deep Q waves, no clear LVH. Furthermore, the patient is described as previously healthy and only 28.
Young, yeah.
While HCM can lurk asymptomatically and present acutely, the absence of those classic ECG hallmarks in a young adult, especially when we have such a clear acute trigger like alcohol for another diagnosis, it's a powerful counterindicator. It's pretty rare for such a significant structural issue to hide itself so completely from an ECG during an acute presentation without any prior symptoms or maybe a family history raising suspicion.
Right.
The key insight here is that while symptoms might overlap, the totality of the patient's profile and the ECG must tell a consistent story. And for HCM, our patient's story just doesn't align.
And for mastery, what are the traps here? What might people fall into?
The main trap is being swayed by the symptom overlap palpitations, dizziness, without thoroughly checking for the specific ECG findings. It's easy to think structural heart issue with those symptoms.
Yeah.
A true mastery point is knowing precisely what deep Q waves and LVH signs actually look like on an ECG, and maybe more importantly, understanding why they are pathological and what their absence implies.
Okay.
Like we said, small Q waves can be normal, but the deep, wide ones of HCM are distinct.
Yeah.
It emphasizes knowing precise ECG criteria and how they relate to the underlying anatomy. The ECG story has to match the suspected disease.
So HCM is definitively ruled out by our patient's ECG. Really highlights how crucial those specific visual clues are. Okay, what about another structural heart issue, choice B, dilated cardiomyopathy or DCM? This one too can cause palpitations, dizziness. I might seem plausible, but I suspect our listeners are already thinking about the bigger picture with DCM, right?
You're absolutely right to anticipate that. Dilated cardiomyopathy is indeed another significant structural heart condition, but its nature is quite different from HCM. In DCM, the heart muscle, the myocardium, becomes abnormally enlarged and thinned.
Thinned, okay.
Yeah, leading to stretching and dilation of the heart chambers. This enlargement compromises the heart's ability to contract effectively, leading to a significant decrease in pumping function. It's essentially a weakened, baggy heart struggling to move blood.
Not good.
Not good at all. Similar to HCM, arrhythmias, palpitations, and dizziness can certainly be symptoms of DCM, maybe due to the altered structure causing electrical instability or the reduced cardiac output affecting perfusion.
Right.
This again creates that initial superficial overlap with our patient's presentation, making it a plausible but incorrect distractor.
So if arrhythmias and palpitations are shared symptoms, how do we distinguish DCM from what our patient is experiencing? What other clinical signs, beyond just rhythm issues, should we be rigorously looking for if this were DCM?
This is exactly where that critical thinking and broader understanding of the clinical picture come in. DCM, especially when it's symptomatic enough to cause dizziness and palpitations, is typically associated with overt signs of heart failure because of that impaired pumping function.
Heart failure signs, okay.
We'd expect to see additional clinical indicators reflecting the body's struggle with reduced cardiac output and fluid retention. For instance, patients might present with peripheral pitting edema, that noticeable swelling in the legs and ankles that leaves a dent when you press it.
Okay.
We might also see signs of increased central venous pressure, maybe jugular venous distension in the neck, or evidence of left ventricular failure, like pulmonary edema leading to symptoms like dyspnea, shortness of breath.
Shortness of breath, yeah.
Particularly when lying flat, orthopnea, or waking up at night, breathless, paroxysmal nocturnal dyspnea, PND. These are the systemic effects of a heart that just can't circulate blood efficiently anymore.
And our patient's history. Does it mention any of these hallmark signs of a failing heart?
Crucially, no. The patient's history does not mention any of these hallmark signs of heart failure. He's 28, previously healthy. While DCM can develop, the acute onset of isolated dizziness and palpitations in a previously asymptomatic young adult without any other evidence of that widespread cardiac dysfunction, like persistent shortness of breath, ankle swelling, unexplained weight gain, signs of fluid in the lungs, it makes DCM highly improbable as the primary cause of this acute episode.
Right.
The lack of those broader systemic effects points strongly away from a chronic deteriorating condition like DCM. It would be highly unusual for DCM to just show up solely with an arrhythmia like this in a young, healthy person.
So it's the profound absence of supporting evidence in the full clinical picture that decisively rules this one out. What are the common MCQ traps or mastery points here?
A significant trap is forgetting to actively look for the absence of key signs. In a multiple choice question, you're given information, but sometimes the most telling detail is what isn't mentioned.
Good point.
If a patient has significant DCM, you'd expect a broader spectrum of symptoms beyond just isolated rhythm issues. Mastery here involves understanding that while arrhythmias can occur in many conditions, the overall clinical picture must fit. You need to consistently ask yourself, if this were DCM, what else would I expect to see in terms of heart failure signs? And then, is that present or, importantly here, absent? This critical thinking stops you being misled by just the symptom overlap.
Okay, next up, choice D Brugada syndrome. This one can definitely be tricky because it also has a connection to alcohol consumption. That creates a compelling yet maybe deceptive link to our patient's story.
Brugada syndrome is indeed fascinating and important, but it's quite distinct from what our patient has. It's a genetically inherited disorder passed down through families, causing a repolarization abnormality in the heart's electrical system, specifically impacting the sodium channels.
Sodium channels, okay.
This dysfunction leaves the heart susceptible to potentially life-threatening ventricular arrhythmias. It's known to be more prevalent in males, and particularly in individuals of Asian descent, though it can affect anyone.
Right.
Like HCM, it's often asymptomatic, maybe discovered incidentally, but it can manifest with palpitations and dizziness due to those dangerous arrhythmias it predisposes to. And here's the trap you mentioned.
Yeah.
It can be triggered by substance abuse or acute alcohol consumption. This shared trigger with our patient's history is precisely what can mislead a learner. Makes it seem plausible, draws attention away from the definitive features.
So the alcohol trigger is there, the symptoms can overlap, very effective distractor. But what does the ECG tell us about Brugada that would just unequivocally differentiate it from our patient's case? This is where that specific ST segment shape becomes absolutely crucial, isn't it?
Absolutely. The ECG in Brugada syndrome has a very characteristic and diagnostic pattern. a signature electrical abnormality that simply must be present for the diagnosis.
Okay, what is it?
You would see persistent ST elevations in leads V1, V2, the right precordial leads, and these ST elevations have a very specific morphology, either a coved type,
Cove.
where the ST segment rises sharply, often by at least 2 millimeters, and then gently curves downward like a dome, followed by a negative T wave. Or alternatively, a saddleback type,
Saddleback. Oh,
which, like the name suggests, has a high takeoff, then a dip, then rises again to an upright or biphasic T wave. Crucially, these ST elevations occur with intact P waves. The atrial activity is normal, not chaotic like an Afib. If you look at the example Brugada ECG in the source material, you can distinctly see these coved or saddleback ST elevations in V1 and V2. They are the defining visual markers.
and their patient's ECG, does it show any of that specific, unmistakable Brugada pattern?
Directly and unequivocally, no. The patient's ECG from this case does not show those specific ST elevations in V1, V2. While the alcohol history is present and could indeed trigger arrhythmias in someone who already has Brugada, the definitive ECG pattern, the cornerstone of the diagnosis, is completely absent. Without that characteristic ST elevation, Brugada syndrome is ruled out for this patient.
Okay.
The presence of a trigger alone, however compelling, is not enough. The underlying electrical abnormality must be seen on the ECG. It's a case where a specific visual hallmark is just non-negotiable.
So the trap is that shared trigger. What are the key mastery points to avoid this kind of misdirection, make sure we don't fall into the Brugada trap?
The primary mastery point here is understanding that while triggers like alcohol can be common across various arrhythmias, they are not diagnostic in isolation. You must verify the specific, often unique, ECG pattern associated with the condition you suspect.
Right.
Learners need to be able to recognize the unique cove or saddleback morphology of the ST elevations in V1, V2. It's also important to differentiate these pathological ST elevations from, say, benign early repolarization.
Oh, yeah, BER.
Right, which can sometimes look like ST elevation in V1, V2, but typically has a different, less concerning shape, often with upright T waves. Recognizing these subtleties of ECG morphology is absolutely vital for correctly diagnosing Brugada. It's really about precision and pattern recognition.
Okay, next on our list is choice E ventricular tachycardia, or VT. This one definitely sounds serious, and the possibility of substance abuse triggering it is also there. Another potential distractor with a plausible historical link.
You're absolutely right. VT is indeed very serious. It's classified as a potentially life-threatening arrhythmia because it originates directly in the ventricles, the heart's main pumping chambers, not the atria.
Right, down below.
Exactly. When the ventricles take over as the pacemaker, they often beat very rapidly and in a highly inefficient, disorganized way. This can severely compromise cardiac output, meaning the heart struggles to pump enough blood, can quickly lead to collapse, hemodynamic instability, even sudden cardiac arrest.
Yeah, very dangerous.
Very. VT is strongly associated with underlying structural heart disease, like a previous heart attack leaving scar tissue, or various cardiomyopathies. And yes, palpitations are common, and it can also be triggered by substance abuse or acute alcohol consumption, again, creating that superficial connection. This shared trigger is precisely why its a tempting option pulls focus from the more definitive ECG clues.
So the severity is clear, trigger can overlap. Sets a good trap. What does the ECG in ventricular tachycardia look like, and how does it compare to our patient's ECG? Especially given what we noted earlier about the QRS width.
The ECG findings for VT are quite distinct and, thankfully for this case, easy to differentiate. The hallmark features include AV dissociation.
AV dissociation.
Meaning the atria and ventricles are essentially marching to their own separate drummers, completely out of sync. You might see P waves, but they bear no consistent relationship to the QRS complexes.
Okay.
However, the most definitive and visually obvious feature of VT on an ECG is the presence of wide QRS complexes.
Wide QRS, that's the key.
That's the key. Typically, the QRS duration is greater than 0.12 seconds or 3 small squares. This widening happens because the electrical impulse isn't following the normal fast His-Purkinje pathways. It's spreading slowly, muscle cell by muscle cell, through the ventricular muscle itself.
Got it.
The heart rate in VT is usually very rapid, often over 120 beats per minute. If you look at the example VT ECG from the source, you'll see a very regular, wide complex tachycardia, a stark contrast to our patients.
And our patient's ECG. That narrow QRS complex we noted earlier seems incredibly important here, almost like a definitive no. against VT.
It is absolutely critical, a definitive and immediate differentiator. Remember, our patient's ECG displayed narrow QRS complexes.
Yep.
This fundamental difference immediately and definitively rules out typical VT. Since the QRS is narrow, we know the ventricular conduction system is largely intact. The arrhythmia is originating above the ventricle supraventricular, not within the ventricles themselves.
Okay.
It's like checking the foundation of a house. If it's narrow, the problem isn't originating in the wide main structure.
So the previously healthy aspect, combined with the narrow QRS, really drives home why VT is incorrect for this patient.
Exactly. The patient being previously healthy makes the typical underlying causes of VT structural heart disease, prior MI, much less probable as an acute first presentation. While some rare forms of VT can occur in structurally normal hearts,
Right.
the narrow QRS complexes on the specific patient's ECG are the undeniable counterindicator. It's a clear-cut exclusion.
What are the biggest MCQ traps and mastery points here when it comes to wide versus narrow QRS tachycardias? Seems fundamental.
It is absolutely fundamental. The most crucial trap and a fundamental mastery point in arrhythmia diagnosis is that instantaneous distinction between narrow and wide QRS tachycardias. That's your first foot.
First step, yeah.
If you see narrow QRS, you're almost certainly dealing with a supraventricular tachycardia, SVT. Problems above the ventricles. If it's wide, then VT becomes a primary concern, and then you get into differentiating it from other wide complex tachycardias like SVT with aberrancy.
Right, SVT with weird conduction.
Exactly. Ignoring this fundamental narrow versus wide distinction is a common and potentially dangerous mistake. Another point is recognizing the severity of VT and its typical link to structural heart disease. Learners often need practice differentiating SVT with aberrancy from true VT in wide QRS cases. But for our patient, the narrow QRS completely sidesteps that more advanced diagnostic challenge, makes the rule out straightforward.
Finally, let's look at choice F6 sinus syndrome, or SSS. What exactly is this condition, and why is it definitively not our patient's diagnosis?
Okay, sick sinus syndrome refers to a significant dysfunction of the sinoatrial SA node. That's the heart's natural pacemaker up in the right atrium.
The main pacemaker, yeah.
Right. It's responsible for spontaneously generating the electrical impulses that set the heart's rhythm and rate. When it's dysfunctional, it leads to a variety of rhythm disturbances because the pacemaker just isn't working correctly.
Okay, like what?
This can include profound bradyarrhythmias, abnormally slow heart rates, periods of sinus arrest or sinus pauses where the SA node just fails to fire for several seconds.
Wow. Gaps in the rhythm.
Exactly. Or it can cause supraventricular tachyarrhythmias like Afib or flutter, or often a combination of both, which we call tachybradycardia syndrome.
Tachybrady. Fast then slow.
Right. Highly irregular rhythms cycling between very fast and very slow rates. SSS is commonly associated with underlying coronary artery disease, age-related degeneration of the SA node, or other chronic structural heart diseases.
Okay, so it can cause irregular rhythms, even tachyarrhythmias. How does the clinical picture of SSS typically differ, both in who gets it and how it presents, from our young patient?
The mismatch in the clinical picture is quite significant here and immediately obvious. SSS is overwhelmingly a disease of older individuals, usually people in their 60s, 70s, or beyond, who have that age-related degeneration or underlying chronic heart conditions affecting the SA node.
Right.
Our patient being a healthy 28-year-old and, importantly, previously healthy with no prior cardiac history makes this diagnosis highly, highly unlikely.
Yeah, the age is way off.
Way off. While an irregular rhythm or even tachycardia can be a feature, the overall context is young age, the acute, singular nature of his presentation, it just doesn't fit the typical demographic or pathophysiology of a chronic, degenerative SA node dysfunction. It would be a real diagnostic outlier to consider SSS in such a young patient without any predisposing factors.
And what would an SSS ECG typically show that's distinctly different from our patient's Afib?
Yeah.
Sounds like that variability is key again.
Exactly. An ECG in someone with sick sinus syndrome might show various abnormalities reflecting that profound SA node dysfunction. Could be significant sinus pauses those long gaps, maybe sinus arrest, a longer cessation of activity, or severe persistent bradycardia.
Okay.
Alternatively, for those with tachybrady syndrome, you'd see alternating periods of tachycardia, often Afib or flutter, and then bradycardia or long pauses after the tachycardia stops. During the tachy phases, you generally still see narrow QRS, maybe indiscernible P waves, similar to our patient's Afib. But the key differentiator for SSS is the cycling between fast and slow, or the profound bradycardia, or those dramatic pauses.
Mm-hmm.
If you look at the example SSS ECG in our source material, you clearly see long pauses in the rhythm indicating SA node failure. That's distinct from our patient's sustained, rapid, irregular rhythm.
So once again, it's a combination, patient demographics, acute presentation, specific ECG findings that comprehensively rules this out.
Precisely. The patient's young age and previously healthy status are incredibly strong counterindicators against SSS. Furthermore, his ECG shows sustained irregular tachycardia, not the typical cycling, profound bradycardia, or pauses of SSS.
Right.
And the history of a single event, the alcohol binge triggering an acute rhythm issue, doesn't align with a chronic degenerative SA node problem that characterizes SSS. The whole narrative of SSS just doesn't fit our patient's story.
And the common traps and mastery points for discerning sick sinus syndrome, what should people watch out for?
The biggest trap here, and a critical mastery point in medical diagnosis generally, is ignoring the age appropriateness of a diagnosis. Many conditions have typical age demographics. SSS is a classic example of a disease of aging.
Mm-hmm.
It almost exclusively affects older individuals, often with other underlying health issues. Assuming a young, healthy person has a condition predominantly seen in the elderly is a common diagnostic error, a significant pitfall.
Right. Be suspicious if the age doesn't fit.
Absolutely. Mastery involves understanding the SA node's function, what its dysfunction implies across that spectrum of rhythm issues, and how that typically manifests clinically and on the ECG. It's about combining physiology, typical patient demographics, and specific ECG findings to paint the full, consistent picture. If the age doesn't fit, it should raise a very loud red flag.
Okay, wow. That was a truly thorough dissection of each diagnostic option. We haven't just found the right answer. We've systematically dismantled why every other choice, despite maybe looking plausible initially, just doesn't hold up. Let's bring it all together now, consolidate our learning, highlight why paroxysmal Afib with holiday heart syndrome really triumphs here.
Yeah, let's recap those critical pieces of evidence that overwhelmingly point to paroxysmal Afib, forging that unshakable conclusion. First, the compelling patient history. Young, previously healthy 28-year-old, acute onset dizziness palpitations 2 days after a bachelor party with excessive alcohol.
Right, the story fits.
That narrative directly triggers the strong suspicion of holiday heart syndrome, a direct known etiological link. Second, the precise objective ECG findings. A rapid, irregular rhythm, the definitive absence of distinct P waves replaced by that chaotic baseline and critically narrow QRS complexes. Each of these features, individually and collectively, is textbook characteristic of atrial fibrillation.
It really is the synthesis, isn't it? The power of bringing all that information together. The patient's story, the social context, the symptoms, the objective electrical findings, that creates such a clear and undeniable diagnostic picture. It's more than just, like, ticking boxes.
Absolutely. A correct diagnosis truly relies on integrating all available information into a cohesive narrative. It's not about picking out isolated clues or focusing on one piece of data in a vacuum.
Yeah.
You need to consider demographics, the complete history, including social context and triggers, presenting symptoms, and then the very specific objective findings from the ECG, interpreting them in light of physiology. When all these elements align so perfectly, like they do for Afib and holiday heart syndrome here, the diagnosis becomes not just clear, but compelling, intellectually satisfying.
Yeah.
That's what transforms information into mastery.
And when we look back at the incorrect options, HCM, DCM, Brugada, VT, SSS, it becomes so evident that despite some initial symptom overlap that might momentarily mislead, each one was definitively ruled out by specific, unassailable reasons.
Yes, and understanding why each was incorrect is just as vital as knowing the right answer. HCM was ruled out by the unmistakable absence of those characteristic deep Q waves and LVH criteria on the ECG hallmarks of chronic structural remodeling.
Right.
DCM was unlikely due to the absence of any other hallmark signs of heart failure. No edema, dyspnea, fluid overload in a previously healthy young man. You'd expect those with a symptomatic dilated heart. Brugada syndrome, despite the clever alcohol trigger, lacked its definitive characteristic ST elevation pattern V1, V2. Non-negotiable for that diagnosis. VT was immediately dismissed by the patient's narrow QRS complexes. VT, by definition, requires wide QRS. And finally, sick sinus syndrome was highly improbable given the patient's young age, healthy status, and the sustained tachycardia, rather than the typical bradycardia, pauses, or cycling rhythms of SA node dysfunction. Each incorrect option, while a plausible distractor, had specific, undeniable reasons for exclusion when you looked at all the facts together?
This truly illustrates the precision required in medical diagnosis and how understanding not just what the correct answer is, but why each choice is correct or incorrect is absolutely key to true mastery. It really is about seeing the whole story the body is telling us. What a deep dive into this clinical scenario. I think we've really seen how breaking down complex medical information piece by piece, integrating history, symptoms, objective diagnostics, it can lead to a nuanced understanding that goes far beyond just surface-level facts. It's about connecting the dots, really seeing the intricate story that the patient and their diagnostics are telling us.
It's empowering, isn't it, to take a seemingly complex presentation, maybe overwhelming at first glance, and by applying systematic reasoning, precise interpretation, core knowledge, arrive at a clear, confident diagnosis.
Yeah.
That analytical process, that journey of elimination and confirmation, is truly the heart of clinical medicine and what we strive for in mastery.
It truly is. So let me leave you, our listener, with a provocative thought. Something to mull over beyond just the immediate diagnosis for our patient. We know that for him, the immediate crucial advice is abstain from alcohol to prevent recurrence of this holiday heart syndrome.
Right.
But for a young, otherwise healthy individual who has experienced this acute alcohol-induced cardiac event, what long-term considerations or preventative strategies might they need to explore to truly safeguard their cardiovascular health, even after this single episode subsides?
Good question.
Is simply stopping alcohol enough? Or does this single event maybe highlight a broader vulnerability that warrants further investigation, perhaps genetic predispositions, other lifestyle factors?
Yeah.
And more broadly, what might this episode tell us about the pervasive, often underestimated impact of lifestyle choices, even seemingly innocuous ones, when taken to excess on even healthy hearts? How our daily habits can quite literally dictate our cardiac rhythm.
A profound question indeed. It pushes us to consider not just the immediate fix, but the holistic long-term well-being and the broader implications of our daily choices for sustained health. It transforms a single clinical case into a deeper lesson about wellness.
Absolutely. Thank you for joining us on this deep dive into a truly fascinating clinical case. We hope you feel not just informed, but truly empowered to continue exploring and connecting the dots in your own learning journey, turning information into genuine insight. Until next time.